So the study that we did was we looked at a finding on a mammogram called a breast arterial calcification. So there are medium-sized arteries in the breast, and they can become calcified. The term is called breast arterial calcification, and this is a finding that can be visible on a mammogram. Most of the time, this is not reported on the mammogram report because there's no known association between a breast arterial calcification and breast cancer. But what research is showing is that this vascular calcification may be linked to future cardiovascular disease. So that's the main reason why we undertook this meta-analysis. We looked at cohorts of women where mammograms were done for breast cancer screening, and the presence or absence of a breast arterial calcification was reported. And what we found was that when women had a breast arterial calcification on their mammogram, they were at an increased risk of developing atherosclerotic cardiovascular disease, including stroke, myocardial infarction, and also all-cause mortality. Well, I think this study is important for primary care physicians and also cardiologists, and really any clinician that looks at cardiovascular disease risk assessment. So right now, when we assess the risk of cardiovascular disease in a primary prevention population, meaning patients that have no known heart attack and no known stroke, we use the pooled cohort equation to help guide us and help determine if we think a patient should be on a statin medication, and also to determine if patient needs intensive blood pressure control and things like that. There are risk-enhancing factors, and there are certain risk-enhancing factors that may be specific to women, like adverse pregnancy outcomes, like gestational hypertension, preeclampsia, also premature menopause is one of those. And with additional research in the future, this breast arterial calcification could be a risk-enhancing factor. When thinking about hurdles, first and foremost, there are not many prospective studies examining breast arterial calcification. In our meta-analysis of cohort studies, we only came across two somewhat high-quality prospective studies, and then we also included 7 retrospective cohort studies. So I think there does need to be some high-quality prospective studies on the topic. So I think that's one potential hurdle. And another potential hurdle is we really don't have good ways to assess the severity of this calcification. When we look at coronary artery calcium scoring, we're able to get a score in Agatston units, and we don't quite have a good severity measure in place. We really don't know if patients with more severe breast arterial calcification are at a higher risk of heart attack and stroke down the road compared to patients with maybe a less severe vascular calcification. So those are I think the two main hurdles, and definitely directions for future research. Just like how a CAC scan is in our guidelines or a coronary artery calcium score, this could be used in a somewhat similar way. So right now, a CAC score in our guidelines says that we can use it for patients who are at borderline or intermediate risk of cardiovascular disease down the road. And if they're really uncertain if they want to be on a statin, we could assess for vascular calcification to either up stratify their risk of cardiovascular disease or even down stratify their risk. So that could be a potential patient population where something like this is useful. Now, the one benefit of using a mammogram to try to predict cardiovascular disease is that this is a test that's fairly widespread, and patients are getting it done for another reason, that being breast cancer screening. So if we're able to use a study that's already done for another reason and extract some new data from it or some new analyses from it, we may be able to save cost, may be able to save radiation exposure, resources, and even time, which I think is a benefit. I think one of the main limitations is that there was a lot of interstudy heterogeneity when we did this meta-analysis, meaning that there's a lot of differences in the studies that we included and a lot of variabilities in the characteristics of the different studies. So that's certainly a limitation. When doing a meta-analysis like this, we have to rely on how the individual studies assess for breast arterial calcification and also how the individual studies assessed cardiovascular disease outcomes as well. The largest study included in the meta-analysis is called the Minerva study. It is one of the prospective studies, and it's published in Circulation Cardiovascular Imaging. It included over 4,000 women with and without breast arterial calcification, and they were able to assess vascular calcification severity by using a densitometry technique, and they were able to show that inclusion of breast arterial calcification can actually improve the prediction of cardiovascular disease events down the road.